So, hello and welcome, all of you who have joined us in this E-Explained event. Now, we've been doing these events, the Explained page of the Indian Express, as well as the Explained section on our website, www.indianexpress.com. That is focused on, over the last 5 years or so, we have focused on presenting to all of you who would want to go a little beyond the news, little deeper, explanations, analysis, background. There's a lot of stuff which often gets left out in the rough and tumble of the news cycle. But a lot of you would want to know something deeper. Explained does that purpose. It fills that gap. It is news. Yes, it's rooted in news, but it's not entirely opinion. So it is kind of just to give you a richer, more fuller understanding. So we've been doing these events for the last about 5 years now. So normally the pattern is that one of our editors has a conversation, an explanatory conversation with an expert in a particular field, and this is the first E-Explained event that we have here. My name is Monojit Majumdar. I am the editor of the Explained section. So today, obviously, there's nothing else that we're talking about, and the person who we have invited here is, of course, Professor K. Srinath Reddy. Professor Reddy, welcome. Thank you very much for being with us. Dr. Reddy, well, as they say in these introductions, needs no introduction. He's the president of the Public Health Foundation of India, which is, of course, one of India's premier public-private healthcare initiative. He's had this long, illustrious career, head of cardiology at AIIMS, and after that, a professor at Harvard for the last since about 2008 or 9, and he's been professor of epidemiology at Harvard, which is particularly important since 2014. But most importantly now, for our purposes, he is the member of the executive group of WHO's Solidarity Trial, which is an effort, a global effort to find a cure for this global pandemic, once in a century pandemic that we have here. Professor Reddy. Talking to Professor Reddy will be Avantika Ghosh, my colleague who has really been tracking this. Avantika has really led the coverage of the Indian Express here of the COVID thing. She's been covering this beat for about 15, 17 years, maybe more. She's just the best that you can have on this. So I won't take too much time. I'll just the way this will function is. Abantika will make a presentation before that, just kind of laying out what is going to happen, the format of the background of this. She has a presentation. There'll be some charts, etc., that she will show, and after that we move on to a. Avantika will have a conversation with Professor Reddy. I may kind of get in the middle. And may I request all of you who are watching us, listening to us now, is if you have any questions, please in the chat box that you have, please send us your questions. We have a list already, and we have a short list of a few questions, but then it's open. It's open for the duration of the conversation. I mean, once the Q&A starts, we will not be able to take. So for the next about 40 minutes or so, when Professor Reddy talks to us, you have the opportunity to send us our questions. And I think Avantika, please take over. All yours.
Hi everyone. So I will just take you through a short presentation. So just a brief overview of how far we have come, where we started from before we start the conversation with Dr. Reddy. So it was on 31st of December last year that the Wuhan Municipal Corporation reported some pneumonia-like illnesses, which eventually now we know as the novel coronavirus disease or COVID-19. India had quite a bit of a head start because our first case actually came on 30th of January. This was of a student who had been flown in from Wuhan. Eventually, there were three students from Wuhan who had been flown in and who developed symptoms, and they were positive. And Kerala did some fantastic contact tracing. That is where it ended. But the second wave sort of started with the Delhi case the Mayur Vihar resident who traveled from Italy, and ironically, he arrived at the Delhi airport exactly one day before we started screening passengers from Italy. That was where the second phase really started. And some of his relatives traveled to Agra. We have all of us have since heard about the Agra model, what was initially one of the models sort of for the entire country, but later there were problems with it. Uh, Mid-March, in a sense, the third phase started, and this is also when the Tablighi Jamaat cases happened, and that sort of took India's cases on a very different trajectory. Currently, we are at a doubling time of about 10 days, and the total number of cases that we have is today is 52,952. And so when I say a doubling time of 10 days, this basically means that on April 27, our cases were 28,380, and today it stands at 52,952. So and this is actually, as we have been told, this has been an improvement, because when the lockdown started, this was a doubling time of 3.4 days. So we have improved, we have sort of increased the doubling time, which means cases are taking more time now to increase. This is a graph showing the number of cases in India, and you see after April 5 how it goes up, and it's currently somewhere here right now, just over 50,000. This is the graph of deaths. It's following a similar kind of trajectory. What we've done actually since the first cases started coming in is that we started airport screening initially for the countries like China, Italy, where cases were being reported, and then eventually on March 22nd we stopped all flights. All international flights were stopped, and 75 districts went into lockdown. And then from March 24th, the countrywide lockdown, from which we are now just sort of beginning to get out in some ways, very limited ways. There was a lot of work to be done. There was, personal protective equipments to be made, ventilators, hospital beds, all of that had to happen. This is just one slide which I thought I'll show how we have stepped up, because on 31st of March, PPE production was just a little over 3,000 per day, and now it's over 1,86,000. This is actually, it may have even gone up. This figure is still 1st of May. So in the last 5-6 days, this may have gone up even further. There's a lot of work the world over on drugs and vaccines, and we started off with a couple of HIV drugs, which we actually administered to some patients, but then there were some there was a Chinese trial where the results were not found to be that encouraging. So now we have moved to hydroxychloroquine, which is to be administered to healthcare workers who have been exposed to the virus, or to people in the family of a positive patient who are the caregivers who have been in contact with the patient. There was also some discussion about population level prophylaxis with hydroxychloroquine, but I think that stands that idea has been kind of junked because of the concerns about the side effects. There is a lot of excitement the world over about remdesivir. Gilead is in talk with some Indian companies about voluntary license. It is possible that that too will happen. It will be a part of the clinical trial. In fact, remdesivir is also a part of the solidarity trial that's happening the world over. It's a multi-country trial. There are many vaccine candidates. Some of them are from India. The most promising vaccine candidate has an India connection, in the sense that the Oxford University has just started phase 2 trials of this vaccine, which Serum Institute of India has decided to manufacture. So we trying to talk about the road ahead is very difficult in COVID, because we normally say in politics week is a long time, and in COVID we have learned that a week is a far longer time in COVID than probably even in politics. So, but here are some of the projections that were shared with the states a few days back. These projections are subject to changes any given point of time. They can go up, go down, depending on how states fare, how containment measures are undertaken. But yeah, these projections do have slightly alarming note to them. So yeah, that is where we currently stand. And with that background, let's start the conversation with Dr. Reddy. So, how have we fared so far?
Okay, thank you, Bantika. Let's look at some of the statistics that have been projected and then try and size up where we are at the moment compared to a number of other countries. Firstly, if you look at deaths as an absolute number and start counting the number of deaths day by day or week by week, you do get some impression that things are actually worsening. Certainly, we want to prevent every single death if possible, but let us look at the death rates. We always have to look at a rate which has a numerator and a denominator. These are the problems of both technologies. Okay, so let me just read out a few figures for you. Deaths per million. I mean, you need a denominator, not just a numerator. Deaths per million in India is 1.3 per million at the moment. In the United States, it is 226 per million. In the United Kingdom, it is 449 per million. In Belgium, it is 726 per million. To repeat, we are at 1.3 per million. So from that point of view, it appears that in terms of the loss of life, we are certainly managing to contain that problem. Of course, we'll have more cases, particularly when we are doing more tests per day. Again, we'll have to look at what are the new cases occurring as a percentage of the new tests per day. Now, when you look at the curve, unfortunately, that curve is a combination of old cases and new cases, and then you're looking at how that curve is going up. That doesn't give you too much of information. On the other hand, if I want to track progress, I'm going to look at 4 areas. Firstly, I'm looking at the number of new cases out of the number of new tests as a percentage. So how many cases have been tested, how many people have been tested per day, and how many turned out to be positive as a percentage per day. Second is using influenza-like illness symptoms for symptom-based syndromic surveillance per week through home visits to primary healthcare teams wherever available, or even a telephonic surveillance. I'd like to see what are the rates of influenza-like illness happening week by week. Third, I'd like to look at what are the COVID positive cases of serious acute respiratory infection getting admitted in the hospital. How many cases of such serious respiratory infection are there and what percentage are COVID? And on a weekly basis, how is it changing? And lastly, what are the deaths per week? Again, I'd like to track that. But again, overall, I'd like to keep deaths per million as an important indicator and see whether that is changing. So unless we get this kind of a picture, we'll not be able to say how well we are controlling. But at the moment, based on most of these, I believe we are actually doing reasonably well. But that doesn't mean that we can be complacent. We need to follow up and see what's happening. But certainly when you compare 1.3 per million deaths with Belgium 726 or USA 226 or UK 449 per million, I think certainly we have done reasonably well.
You know, even the metric of tests per million, that also seems to have some layers of complication in that, because in India, obviously, the trajectory of the disease is different in different states. I mean...
No, I was talking about deaths per million, not tests per million. Let me correct it to you. Deaths per million. We are having 1.3 deaths per million.
Okay.
As compared to 226 per million deaths in USA, 449 deaths per million in UK, and 726 deaths per million in Belgium.
Yes, sir,
tests.
but sir, even with that, there is this criticism that we are not testing enough. If we are not testing enough, then we are missing cases. So it is possible deaths are happening that we are missing because we haven't done those tests. That's also a possibility, isn't it?
Well, deaths which are happening in hospital would almost always be tested if they've been admitted with serious acute respiratory infection. It is only deaths out of hospital which could possibly be missed. There could be a certain amount of misclassification, but still you're not going to have such a disparity.
Right. But sir, lockdown has also actually caused hospital visits to go down. People haven't been able to reach hospitals. We've done a story today. Ayushman Bharat usage has gone down. So that is always a possibility then, right, sir?
Yes, it is a possibility, but then we need to look at what the deaths are overall in hospital as well as out of hospital, and then see whether the deaths, particularly compared to the previous year or the previous 2 years average, have shown a spurt, but taking out the road traffic accidents, because during the lockdown, the road traffic accidents would have come down markedly.
Yes.
So remove that element and then see whether the total deaths, COVID and non-COVID combined, all cause, have gone up quite a lot. If they have, then you can ascribe it to COVID as an additional element. That's one way of looking at the data.
Right. Before I move on to the next question, I would really like to apologize to our viewers for the disruptions. Please bear with us. We are trying to get this back, and I hope there won't be any more after this, but please stay with us. So there is also, when we talk about flattening the curve and how lockdown has worked, we have, for the last couple of weeks, maybe almost a month now, we are talking about doubling time in terms of sort of charting our progress. How reliable a metric is doubling time by itself to decide the stage of the epidemic or the success of our measures against it?
Essentially, the doubling time is a metric they decided upon because they thought this is an exponential curve. Now, the problem about this kind of measurement is that it is also dependent upon the number of tests that you're doing. If you do a lot of tests, then you're likely to find a lot more cases. And therefore, the doubling time of the actually may shrink. But despite doing more tests, your doubling time is actually lengthened. That's a fairly good sign. But again, I would not like to take a count where I'm adding all the old cases and then adding the new cases. I'd rather look at the number of new cases in the numerator and number of tests performed in the denominator and calculate that percentage and do a tracking rather than just being saddled by the number of old tests. But certainly, even taking this particular thing into account, if by doing more tests and you're finding out more cases, still the doubling time is lengthening, that's a good sign. But I would still like to free myself of the dead weight of the previous cases and actually look at the fresh cases that are happening as a percentage of the new tests.
So as we enter the third phase of lockdown, there is a lot of talk about how Sweden has done it and comparisons with how other Nordic countries or even the US have fared. What would you say about Sweden? Do you think they've done well, or?
Well, Sweden chose to go its own path in not having a lockdown. They decided that they will have some degrees of social distancing, but even those have been pretty variable. They made a very conscious decision. But now their deaths are larger in number and rates as compared to their Nordic neighbors, whether it's Denmark or Norway. They are certainly, and they're climbing. So we do not know whether they'll come to regret it like UK did or USA did by delaying it for some time. But certainly, even if you're not imposing a lockdown, social distancing is a very important measure that needs to be followed. And that's been shown world over now, that social distancing is an absolutely critical element of a good public health response.
Sorry, go on. No, I just wanted to. in terms of the number of cases, from about 1st of May onwards, there has been a clear spurt that has been happening. Now, part of it, I'm sure, is a function of increased testing. I mean, we are testing about, what, 80,000 or so now every day. But would it also be that towards the end, the final days of the earlier phase of lockdown, was there a degree of fatigue and people, it was not being implemented that harshly and social distancing was sort of not being, is that a possibility for the spike from 1st May onwards?
Well, I would say that there have been some slippages, and the slippages could have contributed. And certainly, a such slackening of the lockdown, there was a partly and lowering of the restrictions, and also an unplanned violations that took place. But let us also accept the fact that the virus is not in a mode of life. It is still moving around, and it will have new cases.
Yeah.
It is the question of how much we can slow down that spread. That is important. It is not as though we have actually locked it up permanently or we're planning to lock it up permanently. There will be new cases. We have to make sure the spread is, and that we are protecting the most vulnerable people while that spread is out.
So talking about social distancing and lockdown, one of the things about India, and I suppose it's very specific to India, is the stigma that's been associated with it. You know, we've taken social distancing to a different level by stigmatizing the disease and sort of attacking doctors. Is this something unique to India, and why do you think it has happened here?
In the media, as well as even from the politicians, that this is a huge killer epidemic, frightened people. And the feeling that other people can infect you and you can just drop dead, that risk has been exaggerated. We'll end up probably with far less than 1% mortality when all things are done and all cases are properly counted. Therefore, the fact that we are a young population, that we are a rural population, there are many factors that are likely to reduce the mortality in our case, is something of a message that has to be given, that we need to tide through this with care. Certainly, we ought to take care in terms of physical distancing as well as personal hygiene and possibly masks. But we have to ensure that the stigma that is directed at other infected people or against the healthcare providers or against even some of the people from the Northeast who are again stigmatized because of their appearance, I think that whole thing has to be done away with, and we will have to work with the media in order to make sure that this happens.
How can we undo that damage, sir? If the message has already gone out, how do you think we can reverse that message and tell people to sort of, I mean, what is the kind of active messaging we need for that?
I think particularly when we are likely to come out of the lockdown, we need a lot more of community engagement. One of the problems that has happened, of course, in the lockdown is that we have not really engaged the community very much. When you have a community partnered public health, when you have whether the elected local bodies or community-based organizations, women's self-help groups, other NGOs working in the field, they are the ones who can actually convey the message to the people. But if we are only having a one-way communication between the techno-bureaucracy through the media, and we are getting saturated with messages on the TV channels about how many people are dropping dead in USA or Europe or China or anywhere else, naturally the fear factor builds up. I think we need to actually engage much better in our risk communication and build up that sense of social solidarity.
So we've heard a lot about antibody tests first being started, then being discontinued, and a lot of states were very forceful that we want to start it, and then we had to stop because of the concerns about kids. Is that really a very big blow, or is it something that is just as ICMR says, it's just for epidemiological purposes. It doesn't have any real relevance to case detection and diagnosis.
Well, the reason why you use a test is for identification of a person, or for isolation, or for treatment, or for finding out whether the person is immune and can return to work. The antibody test doesn't serve the first two purposes. It only tells you whether you have been infected in the past, recent past or somewhat remote past, depending upon which antibody is positive. But even there, we have a situation where there are false positives, partly because the antibodies can cross-react with other coronaviruses. Secondly, if you apply it on a large scale in asymptomatic people, you're likely to get many more false positives because of a certain mathematical model called the Bayes theorem, in which if you particularly apply it across the population, you are much more likely to get false positives. Therefore, that is one reason why we have doubts about this test. Second is, we do not know how much of immunity these antibodies confer. Firstly, what level of antibodies are required, what is the duration of antibodies acting, and thirdly, whether they by themselves are adequate or they require cell-mediated immunity, which is the other form of immunity, to act together. These are unanswered questions at the moment in this new virus, so we cannot certify for sure that a person who has these antibodies is immune from reinfection. And that's why the WHO has said, we are uncertain, use it for epidemiological surveillance, but don't use it for individual immunity passports.
Coming to some specific states, sir, what is your assessment of what's happening in Maharashtra or Gujarat? The doubling time is far less. Their positivity, Mumbai has 15%, Maharashtra has 8% against national average of about 3 to 4%.
Definitely there are problem areas. It is clear that the virus has spread more, and we are also seeing more severe cases. Now, we are particularly worried, of course, about the slums, not only Dharvi, but other slums as well. I understand now they're taking action, apart from trying to do syndromic surveillance in the slums. They're also trying to take the people who are in the high-risk group, that is the elderly people and people with comorbidities, taking them out of the slums and housing them elsewhere until they feel that the situation is under control. Obviously, they cannot evacuate the entire slum. Similarly, we will have to definitely see in some of these hotspots, even while trying to do the containment methods, how best we can protect the most vulnerable, that is the people who are elderly or with comorbidities or both.
So if I can extend that to deaths, there are these 5 states, Maharashtra, Gujarat, Tamil Nadu, Delhi, and Rajasthan. They account for 70% of all cases as well as 70% of all deaths. But if you include Madhya Pradesh and West Bengal, which are not in the top 5 in terms of cases, the deaths are really high. Madhya Pradesh, I think, is 185 today, and Bengal is about 145, 150. So the number of cases, the fatality rate seems to be differing from state to state quite widely. How would you explain that?
See, firstly, I think the problem is if you're not doing a large number of tests, your denominator is going to be on the lower side because you have deaths in the numerator and the diagnosed cases in the denominator. So that is one reason. If you do a large number of tests, automatically the so-called case fatality rate comes down. So that's one method of doing it. The second, of course, is we do not know what is happening to the treatment protocols, how quickly people are being hospitalized, and how they're actually being treated. So there are 2 elements to this. Both need to be examined.
So there is a lot of, we've all states, even the center at times we've all been through this thing about what is a COVID death, what is not a COVID death. And we have always, everybody has always mentioned comorbidities. Now, how do we decide that a person has had the heart attack, even when he or she has become COVID negative, but the heart has failed because COVID did something to the heart, or some other organ failed because of the effect of COVID, which is expressed at a later time after the infection is gone. So how do we make this fine distinction, sir, in deaths?
We know that COVID is also affecting the heart, not only through myocarditis, but also through thrombosis and so many other conditions. I would think that any death that is occurring in a COVID-infected person within the next 3 months at least should be counted as a COVID death, provided, of course, it's not related to something like a road traffic accident or something else. Because this could have actually set in motion a number of physiological changes which could have resulted in a death slightly later than in the hospital. So I would actually count it that way.
Okay, so let's talk a little bit about, because a lot of questions that are coming from our viewers, listeners, are about what happens after this. So in terms of okay, just numbers. So today we are at about 53,000 or so cases, and doubling rate currently is about 10 or so. So in about a week, we are going to go past what China's rate now, China's infection now is about 84,000 or so. And Avantika showed a projection in the beginning, a government projection saying that by August we can have about 2.75 crore infections. So the question that a lot of people are asking from the perspective of the non-specialist whose sort of life is affected, what now? We now have a lockdown till the 17th of May. There is some panic already. Yesterday, Ahmedabad and Surat kind of completely clamped down because the number of cases has gone up. There's a big cluster. It seems to be developing in Noida, in one of the housing societies. A hospital a lot of cases seem to be emerging there. So after the 17th, what is the way forward?
Well, I don't think we can live in permanent imprisonment of a lockdown. We have to get mobile, not only for the sake of the economy, but also ensuring that schools reopen for children and so on. There are a lot of social elements also that need to be restored. But we have to do it with care. See, you will not be able to test every person on the street, even to catch asymptomatic people with the virus. But we have to depend upon physical distancing, masks in public places, as well as hand hygiene as important elements for a long time to come if we have to slow down the transmission of the virus and also ensure that the deaths are contained and not a surge. And to ensure that we contain the transmission as well as much as possible, I would particularly emphasize the containment between urban and rural areas. Our rural areas are much better protected now. We must continue to protect them by ensuring only essential travel needs and essential transport of essential goods. So that if we can protect that, then we are in a reasonably safe zone. Secondly, I would also say that we must actually ensure that some of the non-essential travel is cut down and some of the work which can be done without necessarily going to the office, non-manufacturing activities, for example, as far as possible, we should try and keep up that level of social distancing even in employment. So if we can continue to do that, at least over the next 1 year, we'll be able to slow down the epidemic, and we may be able to get the virus also to change its pattern. Because it's well known that if you can actually make sure that the virus doesn't have a large human host which it can move around in, it can actually mutate to a less virulent form. So there are multiple reasons why we should do that as well. So I believe we need to resume life, but with great caution.
Okay. So So essentially, there's a new normal coming over the next year or so. No big gatherings and social distancing. Maybe we have to continue to work at a reduced strength. Well, maybe much more of these Zoom interactions with you, sir. Avantika, I think we need to get in some audience questions now. There's a huge list that I have. So the first is Chalapati Somashi. Are you there, sir?
Yeah, I can hear you. Thank you.
Yeah. Good evening, sir. I'll be very quick with my question. Are all the pandemics like this unpredictable, or is there a predictability in that? That is my first question. And in terms of preparedness, there are 2 points. One is we could be reactive, like we are right now, and how much of proactive preparedness we can be working on. In that, which out of these 4 people, process, the material and data, which out of these 4, if you have to emphasize on improvement, which would you do in Indian context? Thank you, sir.
Thank you, sir. The reason why this is an unpredictable epidemic is that it's a new virus, but we have had other new viruses too. But this is a new virus that really moves around with the greatest of rapidity. So its spread is extremely rapid. Secondly, even in terms of its pathology, it seems to affect different parts of the body, and we are seeing different clinical manifestations as well. We are also recognizing that the virus can actually be present in the body without being infective, or it can be infective when it lasts for a long time. Therefore, even the infectivity period is not very certain. So there are lots of elements in this that have become unpredictable for us. We are understanding more and more of it, but then there are still some questions that need answers. Other viral epidemics have not had this speed of transmission or this level of body involvement of multiple body parts and uncertainty about whether there is immunity or not and how long the immunity lasts. So we will get answers to these questions, but this virus is at the moment moving faster than science, but science will catch up. But in terms of what you asked, in terms of people, drugs, material, and data, I believe drugs will come up later on, and material, of course, in terms of personal protection equipment and even testing kits are going to be important. And data will automatically flow when you actually start gathering data. But I think people are the most important, because people, both at the primary healthcare level, particularly, how do you actually ensure that you're doing contact tracing? How are you doing isolation at home? How are you doing health education? And people who are actually the medical personnel, how are they doing the actual testing? How are they doing the treatment? How are they doing the isolation? It is our health workforce that has been unfortunately very weak because of a number of years of neglect of our health system. We have not adequately financed and built up our health system, and we are paying the price for that.
Soham Joshi, are you there? Soham Joshi?
Yeah.
Go ahead.
Hello, can you hear me?
Yes, go ahead.
So, Dr. Reddy, my question is, Mumbai has around 9,000 cases, Ahmedabad has around 4,500 cases, New Delhi has around 5,000 cases. How can you say that community transmission has not taken place? Like, what are the parameters for community transmission in these areas? I mean, I think it's high time that the government or anyone should say that community transmission has taken place to make sure that people are aware. They'll actually be more sensitive to the issue.
Avantika is smiling. Okay.
So are you?
Go ahead.
Well, that's for the government to explain why it's not using that particular term. But I don't think we need to be shy of it, because every single country has had a phase of community transmission. How well they contained it is the important element. But one of the reasons why we are seeing the three areas that you mentioned as being particularly vulnerable is because of the large inflow of foreign travelers. If you look at why the west of the country is much more affected than the east of the country, that is because this is where you have the large international airports, multiple flights landing in, bringing in travelers, and people radiating out from there, they and their contacts. Yeah. And the east, which is less economically developed and much less inflow of foreign travelers and much more rural, has been spared so far. So if you have to take the country as a whole, then probably the government is saying we are not seeing transmission all across the country. But in certain areas, certainly the spread appears to be reflective of transmission beyond the immediate the contacts. So they're calling it local transmission, but that's a matter of semantics. I'm not going to start disputing those words. But certainly, let's not be shy of the fact that every country has had community transmission. It is the question of how well we handle it.
Okay, thank you. Mr. Anup Hiwase, can we come back to you? Mr. Anup Hiwase, are you there?
Yeah, can you hear me, sir?
Yeah, go ahead.
Yeah, I'm there.
Yeah, go ahead. Ask.
Yeah, my question was, if we have not been able to find a vaccine for HIV after 4 decades of research, what chance do we have of finding a fast vaccine for COVID? What is the difference in the two viruses that makes us so confident?
Okay, the question, of course, was why should we feel optimistic about a vaccine for this when we couldn't find a vaccine for HIV?
Yeah.
There could be multiple reasons why, but we also must recognize that a lot of work has been done on the coronaviruses. Particularly, the Oxford lab has done plenty of previous work on coronaviruses, and they feel fairly confident based on that they can actually produce a vaccine, whereas the HIV failed. But we still have to wait and see whether these vaccines are going to succeed or not. But the other element, which is not a vaccine, are for treatment, whether we can actually produce monoclonal antibodies using human cell lines and actually treat people with those kind of antibodies if the antibodies are effective. But still, that's a matter for investigation. We cannot take it for granted right now.
Thank you. Thank you, sir. Okay, the next in my list is Mr. Deepak Sethi. Can we please connect to Mr. Deepak Sethi, please?
Can you hear me?
Yeah, go ahead, sir. Go ahead.
First of all, if I may congratulate both the organizers and Dr. Reddy, this is one of the best conversations I have heard, with some beautiful questions and some outstanding answers to get clarity. There's still a lot of haze, but anyway, I just wanted to say that as an opener.
Thank you, sir. You add to the wonderful questions. Go ahead.
Okay, very quickly. Dr. Reddy, any idea why the same virus on one hand can be totally asymptomatic and on the other hand can cause the patient to die?
Yes, sir.
Why this wide variation? How come this wide variation?
Well, let us leave the genetics out of it because genetics are still being studied. So I'll not get into the genetics, though it could have a bit of a role. But firstly, it does depend upon age and comorbidities. Older the person, the greater the person's likelihood of getting into trouble, particularly if they have had long-standing high blood pressure, diabetes, or coronary heart disease, which actually means that if your blood vessels have been damaged, the virus is more likely to take a much greater toll because it gets a greater foothold. Now, previously it was thought that this was only going and attacking the lungs. Now it is very well known that the endothelium of the lungs as well as the lining of the blood vessels all are affected, and there are something called the ACE2 receptors to which this virus goes and avidly binds. Now, these ACE2 receptors are present all across the body, but particularly in the heart and the blood vessels, and this is where it preferentially goes and attaches itself to. Now, the older you get, the more likely your blood vessels have been damaged, particularly if you have had high blood pressure or diabetes. And the younger you are, the less likely that the damage has been there. Therefore, the virus, even if it enters your body, cannot cause that much of damage. Beyond that, are there other factors? Women seem to be better protected than men. And one of the reasons that's coming out now is that the testes are quite rich in the ACE2 receptors. And the virus seems to be lodging there and even find a reservoir there and may actually start infecting for a longer period. So we do not know. There are multiple differences. But if you are younger and if you do not have any of these comorbidities, you are actually much more likely to survive. And even if you are older, if you do not have these comorbidities, again, you can still survive. Like some optimistic stories have come out of Italy, where a 102-year-old woman walked out, and in Kerala, where a couple in their 90s walked out. So the important thing is we must make sure that we don't get into these kind of diseases which actually make us more vulnerable to the virus.
So, Mr. Reddy Swain, this is the Danish ambassador to India. Will you connect to Reddy Swain, please? Go ahead, Excellency.
Thank you very much. Pleasure reconnecting to Professor Reddy. I have two questions. What should have been done differently locally in India and globally? Second question, what are the long-term consequences of coronavirus for the public health of India? Thank you.
The first question is, what could have been done differently in India? I think we could have shut down the international flights earlier and been more careful about a lot more people getting infected by returning people. But then that's a choice countries make. We were also determined to bring back Indians who were stranded abroad. We decided that wherever they are, it's our duty to bring them back, and we are still bringing them back. That carries a risk, but we accepted the risk. Whether we should have done it or not is a different issue. Second, of course, is I'd go back a little farther. If we had actually invested in a much stronger health system, and particularly a good primary healthcare system, we would have been faring far, far better. Now, as far as the world is concerned, I think we need to look at immediately in terms of what the responses could have been, whether we could have actually recognized this as a potential large global pandemic even in early January and acted much faster like some countries did, or waited long and then paid the price like UK and USA did. The different countries have reacted differently. But one thing that the world must do is to make sure that the kind of ecological despoilation that we are indulging in, the deforestation, the huge investment in livestock breeding and animal foods, the rampant urbanization with the destruction of forestry, which is actually creating a conveyor belt between viruses of the wild, veterinary population and human beings, we have to revisit that entire falsified ecological model and then get back into greater harmony with nature. This is not what I'm diagnosing for the immediate past, but I'm talking about all the mistakes that we have made over the last 50 or 60 years. And going forward, if there's one lesson that COVID virus has taught us, it is not to take ecology lightly. The second question is, you asked about the vaccine. I think you asked about India's position on the vaccine. If there is a vaccine that is produced anywhere in the world, I think India has the firepower to produce vaccines in the large quantity at low cost. We can actually become the supplier of the world. And that is something that we should actually utilize appropriately.
That is very okay. So, Avantika, you have a list?
Yeah.
Go ahead.
Mr. Yash Arya.
Please connect to Yash Arya, please.
Yeah.
Are you there? Can you hear?
Can you hear me?
Yeah, I can hear you.
So my question was that let's say if a person is connected, there could be a good chance that he might not gotten a virus, but in future he might get a virus. So I simply want to ask that, so how frequently we have to get tested so to make sure we do not get the virus?
So, Yash, from your photo, I see a young person. Firstly, there is no guarantee that if you test negative today, you can get infected tomorrow or a week later. So you can't keep on getting tested just to find out whether you have the virus or not. The antibody test actually can tell you to some extent whether you have been infected and have built up some sort of antibodies. But as I mentioned, there could be false positive tests. That's also not a 100% guarantee. The best thing is to try and maintain your social distancing and physical protection measures, because one of the issues that has come up is, are these antibodies, even if they're genuine, likely to protect against reinfection, and if so, for how long? We still do not know the answer. So we still have to be on our guard. But the good news for you is that since you're a young person, even if you do get infected, you are likely to walk away very lightly.
Mr. Kartikeya Gupta.
Thank you for the Indian Express for such an enlightening discussion. So I wanted to ask a question. So as many health experts like Professor Jaiprakash Mulyal propounds that herd immunity is the only solution in the future. So what is your take on it?
Well, firstly, herd immunity requires about 60 to 70% of the population to be infected. It's actually herd protection, not really herd immunity, though the term herd immunity is used, because if about 70% of the population are infected and the other 30% are there, and the virus passage is blocked because it's going from an immune person to an immune person, then the other 30% may be protected. But if the person who is not immune goes to another herd, let us say another city, where the infection has been only there for 20% or 30% of the people, that person is still likely to get the virus infection. So it's actually not permanent immunity for everybody. But second thing is, because even in China and elsewhere, even in the USA, where large number of antibody tests have been done in California, they found that only about 2.5 to 4% of the people have been so far exposed to the virus. So even with its rapid spread, it will take quite a few years for 60 to 70% of the population to be exposed. And if you want to move around freely without any of the physical distancing, etc., maybe it will come faster. We do not know, but that's going to kill a lot of people suddenly, because we want to have controlled exposure rather than a sudden exposure. And finally, we also do not know whether these antibodies are protective or not, and also whether the virus will remain stable or mutate. Like, for example, influenza viruses do change, and that's why we require new flu vaccines every 2 or 3 years. So we have no idea whether this is going to be a permanent herd immunity, even if it occurs. So the time it's going to take, the uncertainty whether there's going to be immunity at all or not, and the likelihood of massive surges if we just walk around freely, those are the reasons why herd immunity is not the solution we should be looking for right now.
Right. Mr. Kunal?
Yeah. Hello, can you hear me?
Yes, go ahead.
Actually, my question is that India has been recording very good recovery rate, around 27%. So in absence of any medicine or any treatment, how the patients are recovering first? And second is, if the recovery rate is going past 50%, can we think of relaxing the norms? Thank you.
Sir, the recovery rate is a bit of a strange statistic, because most of the people will recover anyway. They're timing the recovery rate from the time they tested and found a person positive. So that timing, depending upon when you're giving the analysis, could be 1 week, could be 2 weeks, could be 3 weeks. And unless we adjust for that, we really will not be able to calculate the true recovery rate in the population exposed. So, but anyway, I don't think we should take the recovery rate as the indicator of whether we are safe or not. Ultimately, almost 90 to 95% are going to recover. Even if 15% get seriously ill and only 5% require, ventilators, most of them also will recover. So the recovery rate will be actually pretty high over a period of time. What we really need to do is to make sure that the rate of rise of infection, as I've already indicated, by different indicators, the number of new cases per number of new tests, by syndromic surveillance of influenza-like illness, the number of deaths happening per week, that all of these indicators are fairly stable before we start loosening our own social distancing or other measures.
Dr. Omkar Chaudhary?
Yeah.
Yes. Can you hear me?
Yes.
Yeah, I can hear you, sir.
Yeah. I am a healthcare professional. What I see for COVID-19, we are treating it as an infectious disease as per the ICMR protocols. But I find in the general population, people are afraid to come out and say, I have flu-like symptoms. And it's because, again, the stigma of the attached to this infection. So what should be the approach of the government to prevent this stigmatization of COVID-19 patients or their contacts, and so that people can really easily come out and get themselves tested, so that we can actually narrow down the population which needs to be taken.
I fully agree with you, sir. I think we need to change the language of communication. We should stop calling it Vaishik Mahamari. We should just say COVID ki bimari. We should convert it into an illness rather than a very dangerous, killer. Unless we change the tone and tenor of our communication, people are going to still feel scared and start stigmatizing. But again, this requires a good deal of community level communication. It can't be done just through mass media. You need that, of course, but you also need a lot of community level action.
Vijay Lakshmi Bose?
Dr. Reddy?
Yeah, yes, please.
Dr. Reddy, this is Vijay Lakshmi. I just wanted to say that you're putting a lot of the community engagement responsibility on CSOs who may not have the necessary resources, bandwidth, or outreach. What about distance education, telecommunication, and using smartphones?
Of course, we should use all communication technologies. Mass media, social media, smartphones, everything. But there is nothing as comforting as your own self-help group or the local community leader coming and saying not to be afraid of, or at least let's not stigmatize. I mean, one of the worst things that we have seen is the way the migrant labor have been treated, not only here, but when they went back to their villages, the sarpanches put up barricades because of the scare. We do need a much more humane approach, which only humans can bring through direct contact as well and conversation. But certainly, we must use every single instrument at our disposal, mass media, social media, smartphones, everything. But mobilizing the community at the ground level, like Kerala has done wonderfully, some other states are doing it beautifully. I think that's very important. Look at the Northeast. They're doing their community mobilization so wonderfully. There is a certain element of efficiency in technology, but there is a great deal of empathy in human interaction.
Yes, please go ahead.
Yeah, good evening to the complete team. I think it's a wonderful discussion what we are having. My question is like around the line of treatment, what is being talked about a lot, like various kind of allopathic treatments are being given as treatment to the patients, and like there's also talk about the vaccines and all. My question is around the homeopathic, which is I think a very historical treatments what we have had in India and worldwide also. homeopathic has played a very big role. So why the government of India is not pursuing this as a line of action or promoting this? Because there have been number of studies which have been done by a lot of people, and where number of treatments have been done through this mode. So why the government is not taking a very good step in this direction? Thank you.
Sir, I'm very respectful of Indian systems of medicine, and I think they have a lot to offer, particularly in building up immunity through much more healthier living habits that they promote. In terms of actual treatments of COVID, I think a number of trials are being planned, or number of studies are being planned, let me put it that way. And between Ayush and ICMR, they are collaborating also to see which are the areas that should be appropriately evaluated through research studies. Nothing prevents, of course, people from taking whatever medicine they feel confident about, and even Ayush has put out some advisories. But in terms of actual research to find out how effective these are as compared to others, I think some studies are being planned, and we should await those results.
Dr. Chandrakant Leheria.
Hello. Yeah, I think, can you hear me?
Yes.
Yeah, I can hear you, Dr. Leheria.
Dr. Reddy, good evening. And I'm sorry, last time there was some issue with the mic. So my question is that we already know that any of the disease has a lot of social and economic impacts. And pandemic simply raised that impact to the next level, really high and widely visible. So when in this pandemic, we are hearing a lot about medical and healthcare, but there is not enough discussion or attention, or at least from policymakers, on social and economic impact of this pandemic and how to handle this, especially when the pandemic is going to stay for a longer duration. So any thoughts or reflection on that? Thank you.
Firstly, Dr. Leheria, I think we must actually ensure that the discussion doesn't remain around hospitals and ventilators, and focus a lot on public health, which has a number of social determinants of health, social and environmental determinants of health. Very few people are going to be requiring hospitalization, and very few are going to be requiring ventilation. About 85% of the people will be treated in primary healthcare settings. So building up our primary healthcare system with appropriate referral, of course, to advanced centers is a critical element. Secondly, strengthening of our district hospitals for that advanced care is also important. But looking at the social and environmental dimensions of public health and building up a primary healthcare system is going to be absolutely critical as well. And those are the neglected areas that we must focus on. As I mentioned elsewhere, ultimately when this battle is won, the symbol of our success is not going to be a ventilator, but the frontline health worker knocking on a door and finding out whether somebody has fever and cough.
Fantastic, fantastic.
But certainly the social and economic impact are important, because we need to ensure that we do not have the banana peels of our public health failures on which the economy will keep slipping. On the other hand, if we invest adequately in health, the health can actually become a propeller for taking economy to greater heights.
Absolutely. Wise words from a person who knows this subject very well. Thank you so much, Dr. Reddy. I think we've had this wonderful discussion. The takeaways, COVID is not going to disappear. Herd immunity, herd protection, as Dr. Reddy suggested, we say, is going to take some time to come. 60 to 70% of 135 billion is not going to be easy. We have to invest in our basic health infrastructure. We have to enforce social distancing. Life will change, and we have to start getting used to the new normal. Thank you so much, all of you. Thank you so much, Dr. Reddy. Absolutely wonderful.
Thank you, Dr. Reddy.
Thank you very much.